Welcome, everyone. I believe we're ready to get started. I'm so thrilled to have you join us for this first ED Stop Suicide QI Collaborative Welcome Session. We'd like to take attendance today, so please enter your first and last name and your hospital into the chat box. My apologies, the slides are not moving. Give me a second. Okay, maybe there's a slight delay. My name is Laura Aird. I'm the Senior Project Manager for the Collaboratives domain within the EMS for Children Innovation and Improvement Center. We'd like to acknowledge our sponsors and collaborators, HRSA folks. I can't tell you how much they have helped us put this collaborative and many other EMS for Children initiatives together. They are a true partner, and we are very grateful. You can see the agenda on screen. I wanted to give you a few reminders. This is a meeting rather than a webinar platform. So that means that there's a possibility that you could become unmuted. So please be cautious and keep yourself muted unless you are a speaker or we are in the Q&A session. We've talked about attendance. I wanted to let you know that this meeting is being recorded like all collaborative sessions for this QI collaborative, and that the recording and the slides will be shared and posted online as soon as possible. You've all heard me mention the participant demographic form. We really would like all of you to complete it. We've had less than half of you complete it. You'll hear a little bit later about the details of that. We'd like you to feel included, and it's a very brief form with a few questions. So if you get a chance, please do complete that form. I will add the link to the chat in a little bit to see if you can do that. I'd like to turn it over to my colleague, Angela Nguyen, who's going to proceed with the next section.
Good morning, everyone. I'm glad that everybody's here. So as Laura said, I've been collaborating on this a collaboration, I guess. I'm the manager of clinical pediatric social work within the University of Texas, Austin, Department of Health Social Work within Department of within DelMed. I'm going to start off with just reviewing a little bit more, giving more background about why we're here. So the EMS program is a federal program housed within the Service Administration. I feel like I still see my name up there, but just go along with me. It is the only federal program focused.
There's a delay of some sort.
All right. I swear there's a slide there, and it will tell you all that I'm telling you right now. It's the only federal program focused exclusively on providing pediatric emergency care. The primary goal of the EMSC program is to reduce childhood death and disability due to severe illness and injury. Its primary work is to enhance our current emergency care systems to fully integrate pediatric specific needs. This is needed because, as you all know, our emergency care systems were not designed with children in mind. All right, I'm just going to keep going, Laura. Okay, so.
Sorry, but I've got a frozen situation here. My apologies.
All right, and I believe that some of these infographics that we're going to be on the slides will, you're going to have access to the slides as well as in some other information we'll be providing. There we go.
Just 1 second. One of my colleagues is straightening things out.
Wonderful. Okay, so now we're ready for the so that is a slide that I was just talking about. So next we're going to move on to what is EMSC. So while EMSC is a relatively small federal program, there are 5 primary investments within the EMSC family. So if you can move to the next slides, Kate. Thank you. So the EMSC state partnership program's goals are to be present in every state and provide support to local teams. They can help identify resources and advocate for your needs. If you don't know who your EMSC SP program manager is, there is a grants contact list on the EIIC website, or send an email and we can help connect you. PCARN is the evidence generation arm encompassing 18 children's hospitals and affiliate EMS agencies. PCARN is the leading network for pediatric emergency care research. It has over 150 peer-reviewed manuscripts published to date, and is the evidence generation arm for the pediatric emergency care, including the of EBGs and clinical decision support recommendations, for example, head CT and closed head injuries. The EMSC Data Center is the accountability arm of the program that reports back on the impact of all the EMSC family investments. Their work includes hosting national data collection efforts, such as the National Pediatric Readiness Assessment. Last, the EMSC Innovation and Improvement Center is the quality and implementation arm of the EMSC program, supporting communications, partnerships, educational resources, and hosting national QI collaboratives such as this one. All activities within the EMSC programs are free and open access. Our goal is only to ensure all children have access to high quality emergency care. So those are the agencies. And now we want to briefly introduce you to our EIIC administrative team. Again, this will be in more information on these individuals that are in the toolkit that you'll get towards the end. So we can move on to the next one. And this is our advisory committee. So we're grateful for everyone who supported the planning and implementation of this QI collaborative. More details are in the welcome kit as well, and we'll discuss that later. We also want to express much gratitude for those who help us as experts. They're going to be sharing their knowledge through webinar presentations or expert presentations known as fireside chats. Several participate within ED site teams in their own institution. And now we want to talk about who is here. So who is the collaborative? So we have 89 teams, and this graphic kind of identifies where everybody is from. And we want to share this information with you because we want to show that no matter where you're from or what your size of your emergency department or even more, or other demographics we're about to share, everybody has a place. We all have to learn from each other. So the more we share, I think the more that we'll learn from each other. Here's just a quick infographic about what states are represented. So the green states have at least one ED site team, while the gray teams states do not. And then this chart on the right shows the number of teams in each of the 31 participating states in DC. I'll give you a second to look at those. Okay. And then what type of EDs? What populations do you serve? So we have a majority really is the general EDs, which is great. We also have a large number of pediatric EDs that only care for children or have a separate pediatric ED within a general hospital. And then we have some standby EDs with physicians on call. And this is just to review the size of the population that you serve. So that really is around the pediatric volume versus the total volumes of the sizes of the emergency departments. And this is really the slide to help us understand of who we are and who all's in the room. So this was the patient, this is the participant demographic form that was due last week. So if you have not filled it out yet, I think that Laura or someone will add that to the chat so that you can fill it out right now, because it's super easy to do. So if we look at the participants, it's kind of small, but as you can see, we have varying experience. So regardless if you're brand new in emergency medicine or you've been here for a while, there's other colleagues here in the collaborative, as well as QI experience. So if you are brand new to QI or you've been a leader of initiatives, we have colleagues here at the table to learn from and to collaborate with. And then participant credentials. This, I think the work group to the marketing and try to encourage people to join did a great job. We have a great variety of different individuals at the table, and that's really what we need, that interprofessional work. So we have nurses of varying different responsibilities, physicians, social work, master's level providers. So it could be APPs, it could be master's level mental health, child life, and MS and PhD. So under physicians, it's MDs, NDOs. So if, again, we don't have, we only have about 45% of people out. So it would be really helpful if we had the rest of that information to share with everyone. And then I'll leave you guys with the idea that this is supposed to be a collaboration. So we want everyone to feel comfortable to come together and teach about your experience, your knowledge, and then let's stay open and curious and learn from others. We want to be supportive of one another and make it an environment where everyone feels vulnerable enough to speak up and to give feedback and to help out each other. So please be active, ask questions. Don't feel like it's a question that everybody else knows the answer to. Please, if you're asking, someone else probably is as well. And success equals improvement. So everybody in this collaborative is here because we want to improve the care for our pediatric population. So every little step that we can take, some programs might make bigger strides because of the resources or where they're at in their stages. So everybody just know that we're coming to the table and we're just looking for improvement. And so be proud of those steps. All right, so now that you know who all's here, I'm going to hand it over to Chip Schreiber to explain a little bit more about our public health emergency.
Thank you, everyone, and it's wonderful to have such a cross-section of the country and hospital types and provider types part of this collaborative. I think that's truly the goal. I'm a clinical child psychologist on the faculty in pediatrics and psychiatry at the UCLA School of Medicine. I'm part of the Lundquist Research Institute at Harbor-UCLA and senior advisor for the Terrorism and Disaster Program for the National Center for Child Traumatic Stress in the UCLA Health Department of Psychiatry and Biobehavioral Sciences. I'm also the co-lead for the mental health group in the ASPR Western Regional Alliance for Pediatric Emergency Management, RAPM, and the co-lead for another exciting HRSA innovation, the co-lead for the mental health domain in the Pediatric Pandemic Network, which is a national initiative. Next slide, please. So, you know, in the last few months, even as this project was being put together, we've really had surge on surge. So in the winter months and the fall, there was COVID-19, RSV, all sorts of other infectious disease, really on top of a chronic surge in mental health emergencies. And we know that suicide is actually the second leading cause of death for adolescents in the United States. And that all of this combined has just created kind of a synergistic negative surge impact on healthcare systems and the ED environment in particular. So now more than ever, there's an urgent need to line up the arrows and move the ball forward for pediatric mental health care across the nation. And we really think, at least I think, that the approach is one that's comprehensive across different touch points. It's trauma informed. and necessitates a continuum of care solutions throughout touch points where children and adolescents live. We also know that mental health issues are compounded by access to care and disparity issues. Next, please. And, you know, in COVID, we saw some states, we saw this hospital and emergency medicine PEM physician at Children's Colorado declare a mental health state of emergency, really for the first time, I think, in history. And that was followed very quickly by the next slide. Okay, well, this is a timeline actually showing the history of the movement in the pediatric mental health emergencies arena, kind of within the HRSA context. And then actually the thing I was just referencing, an emergency declaration that was jointly released by the American Academy of Pediatrics, the American Academy of Child and Adolescent Psychiatry, and the Children's Hospital Association in the fall of 2021. And then that was followed by another 134 organizations, including my own, the American Psychological Association, in 2022. Quickly thereafter, some recommendations on routine screening for anxiety and depression in very young children, pre-adolescent, in fact, in the primary care context. And most recently, the American College of Surgeons Committee on Trauma has released requirements for mental health screening for all pediatric trauma patients in verified trauma centers effective August 23. So a lot of things really coming together, and a lot of great ideas are actually in this HRSA critical crossroads document. You can see the image of it on the right side of the slide. The link is there, and you can actually use the QRS code, and we'll also make that available to you, through communications that follow. Next. And this is just the joint declaration from AAP, AACAP, and CHA. And then the Surgeon General released an advisory very shortly thereafter, also kind of historic. Next. And I can just tell you from my own state, California, and we're excited that so many hospitals in our state are participating, including my own, Harvard UCLA. What's striking to me, and this is a slide borrowed from the State Health and Human Services Agency around a youth behavioral initiative that our state has just started. And it's clear, looking at just California, that the leading cause of hospitalization for kids under 18 are mental health issues. And the rate of suicide among Black youth in California doubled in the 6-year period, 2014 to 2020. So very striking. Next, please. And this is national level, population level metrics from CDC using the Youth Behavioral Health Survey tool that many states participate in. And this was in 2021 showing extraordinary levels of persistent sadness and feelings of hopelessness in the last 12 months, kind of through the early pandemic period into 2021. 44%, nearly half of youth reporting that, and 37%, kind of a similar metric, experiencing poor mental health during COVID-19. So at the population level, we know. And the suicide rates have been on the rise. This is data before COVID. You can see kind of the trend up there over time. Next. And there's horrendous disparities, especially when you look at from the perspective of co-occurring major depression and substance abuse in adolescence. That's a very, very frequent co-occurring condition and presentation. And you can see less than 12% of adolescents with major depression and a substance use disorder receive treatment for both of those syndromal conditions in the 2011 to 2019 period. So they're talking about the need for improved coordination between service delivery systems. And this initiative is definitely very much tied to that. You can also see in some of the fine print that Hispanic adolescents with co-occurring disorders, Asian, Native Hawaiian, and Pacific Islanders with major depression, also with significant disparity issues in this particular study. Next. And COVID. Add COVID on top of what you saw in those other trending. 3 in 10 in the 2021 period knew someone who had died of COVID, and that also had a major impact on their mental health. Next. Parents also extreme difficulty in accessing care for their children, either for themselves or for their children. And that's, just almost a year old, over a year old. Nationally, internationally, actually, this is data from around the world. Pediatric depression and anxiety looks like it doubled. It's just striking metrics, doubling of pre-existing already significant challenges in these areas. Next. And the suicide rates, 62% increase in the 2010 to 2020 period. And you can see some of the disparity issues there. We won't have time to go through these, but all of this information we'll make available to you. Next, please. And this is study out of PCARN, which is another one of the HRSA, pediatric initiatives, emergency care initiatives. And this is a study by our colleague Jennifer Hoffman at Lurie Children's Hospital in Chicago and colleagues, basically showing an association between youth suicide and mental health professional shortage areas. And this is from the period pre-COVID, 2015 through 2016, 5,000 suicides in the 5 to 19-year-old age group. 2/3 of US counties in the same period had a mental health professional shortage. And what they were able to demonstrate is increased risk tied to living in one of these designated mental health provider shortage areas, and also associated with greater risk of firearm suicide. And there's also some co-occurring social determinants of health that go along with that: higher poverty levels, lower access to insurance, and educational attainment in parents. Next. And this is just kind of what that looked like. The dark blue in the lower half of the slide shows you the health provider shortage areas. So you can see a very large chunk of the country. And we're excited that many of those shortage areas are in this initiative. So that's really important that we have you engaged. Next. And this is just sort of a county level view. Sometimes people think California has a surplus of providers. Well, when you look at the state as a whole, you can see the dark green is a high needs. So even within the shortage, it's further delineated into gradations of need. You can see the dark green are the high needs areas, a lot of those more rural frontier areas, and even areas that encroach on urban areas also evidencing shortage. And in that very, very lower right little box, that's actually Los Angeles County where I work. And you can see that even within LA County, at the northern top there, you can see very dark green areas. And we've actually been doing ED mental health boarding tracking in Los Angeles County together with the LA County EMS agency. And we're really seeing a linkage between some of those shortage areas on this map and the ED boarding in real time in LA County. Next, please. And there's also 988. That's a system that's also trying to address the ED surge. And the idea, when built out and implemented across the country, is that the 988 system will allow diversion of mental health emergencies, including those for children and adolescents that don't have a medical need to go to the ED, to go to defined mental health facilities and kind of reduce ED surge, reduce time to appropriate mental health levels of care. And, it's sort of a win-win for the EMSC system and also for youth and families trying to get access for mental health emergencies, reduce reliance on law enforcement and the EDs in particular. Next. And I turn it over to my colleague. Thank you.
Thank you so much, Dr. Schreiber. That was a tremendous background, and we're so grateful for your expertise as we've gone to develop this collaborative. We're also grateful, as Dr. Schreiber mentioned, to have Dr. Jen Hoffman, who you just saw much of her data, as one of our fireside chat experts, as well as many others, as Angela presented earlier. I serve as co-director for the MSc Innovation and Improvement Center along with Dr. Charles Macias. I'm housed in Austin, Texas with UT Dell Medical School. And I want to apologize for some of the technical difficulties we've been having this morning. For those of you who have been impacted by the winter storm, we feel the challenges that you're facing, as we too, many in our team have been with power outages and the like. So thank you for bearing with us as we have pivoted this morning. So over the next few minutes, I just wanted to talk a little bit about why we within the EMS for Children Innovation Improvement Center are involved in quality improvement collaboratives, and why the emergency department in particular is an important area of focus. You've just heard a lot of that background from Dr. Schreiber about the increased strain that's been placed on EDs. And we often think of them, of course, as a healthcare safety net. He talked a lot about the increased rise in visits, and we saw those even when we saw a 50% decrease in overall pediatric visits to emergency departments. That occurred during COVID, but mental health visits continued on the rise even during that. And we now know that as a country, we're spending about $250 billion annually on mental health related conditions. These patients have had exceedingly longer lengths of stay, possibly related to the decrease in inpatient pediatric units. And this has been further exacerbated by the viral triple-demic that we all just recently experienced. So when it comes to just emergency department care, just to give a little bit of background on that, every year, at least prior to the COVID pandemic, we see about 35 million pediatric visits to emergency departments. And for those of you that are not part of children's hospitals, and those of you who are, it's important to realize that 80% of those visits occur in non-children's hospital EDs. And the average of those sees fewer than 10 pediatric patients per day. In fact, what we know is about 50% of hospitals see fewer than 5 pediatric patients per day. And this makes it really challenging to maintain everyday readiness, but it's also important to realize that even though it seems like you may not have a large volume of pediatric patients, this is where the lion's share of patients are being seen. And so collectively, we have a responsibility to figure out how we can meet their needs. As you all know, there's no universal licensing requirement yet for children, and there's variable readiness. We know that less than 50% of EDs currently have quality improvement plans that even include children. And that means reflecting on all care, not just mental health related care. And from a study that was done by Kristen Ray and colleagues out of Pittsburgh, we know that the great majority of children have access to any emergency department. Only about 50% live within a high-ready ED, but among those, almost 90% live closer to a non-pediatric ready ED. So the point being that these children are coming to you, to your emergency department, if it is the closest ED. Many of you are aware of the National Pediatric Readiness Project. This is a project that's been sponsored by the Health Resources and Services Administration, the EMS for Children program, who is our funder, and we are grateful for their funding. And in collaboration with 3 national professional organizations, the American Academy of Pediatrics, the American College of Emergency Physicians, and the Emergency Nurses Association. And the work of this project really stems from National Joint Policy Statement or Guidelines for Readiness in Emergency Departments. This started over 2 decades ago with an initial Joint Policy Statement in 2001, revised in 2009, most recently in 2018, and really formed the basis for a national 2013 assessment of ED readiness to meet the needs of children. Like what we are here for today, the National Pediatric Readiness Project is truly a quality improvement effort. It started with a baseline understanding of the current state of pediatric readiness, which was the 2013 assessment. Over the last decade, we have engaged in a number of national quality improvement intervention strategies. Those have included educating providers, getting resources together, providing tools, developing QI collaboratives on a national scale. And then most recently in 2021 was the national reassessment, the results of which will be coming out hopefully in the next few months. And now we are on track for our next intervention strategies for improvement. And it's important to realize that when we think about pediatric readiness, we're not talking simply about equipment and supplies or medications, but we're talking about the entire system's level of preparedness to meet the needs of children. That includes quality improvement and health care, providers' competencies. It includes safety measures and includes policies and procedures like those related to mental health care. We have been ecstatic for the level of engagement in pediatric readiness efforts. This was from the 2021 assessment. So even in the midst of a global pandemic, there was about a 71% participation rate across all acute care hospitals within the United States, and lots of wonderful information to be gleaned from that. The reason this is also important is we now know that pediatric readiness indeed leads to improvements in survival. And some papers that were led by Dr. Craig Newgard out of Oregon Health Sciences University has demonstrated as much as a twofold decrease in mortality among injured children who are evaluated at trauma centers. Dr. FAEMS and colleagues out of Pittsburgh has demonstrated that there's as much as a fourfold decrease in mortality for critically ill children who present to pediatric ready EDs. And overall, in a more recent study, Dr. Newgard and colleagues showed that there's as much as a 60% or 76% lower odds of in-hospital death if an emergency department is ready. And if all of us took steps to ensure that RED were ready, as a nation, the estimate is that we could be saving as many as 1,400 deaths every year. And this impact has a long-term impact that lasts beyond a year. So I just wanted to share a few results from the National Peds Ready Assessment that directly relate to the purposes of the ED Stop Suicide Collaborative. One is that having a champion, which in this regard is really a conceptual framework, someone who's overseeing pediatric emergency care efforts, is associated with as much as a 16-point increase in weighted pediatric readiness scores. About 30 or more folks, because we haven't had all of the demographic surveys completed, who are participating in this collaborative have self-identified as PECs. Those of you who haven't, I would say, are still serving in this role in some capacity, in that you're helping to champion pediatric specific needs within your emergency department. We also know that having a quality improvement plan that integrates pediatric needs is associated with as much as a 25-point increase in weighted pediatric readiness. So what does this mean? It means that hopefully, by way of participating in this work, will help to introduce you, if you haven't yet been involved in quality improvement efforts, and about a third of you have not, how to engage in QI plans within your emergency department. And this will hopefully launch enhancements in your overall readiness within your emergency department. About 2/3 of hospitals have a family-centered care plan. This is critically important in mental health, especially when there's significant boarding or we don't know the final disposition of these patients and the challenges and stressors that are being placed on these families. About 3/4 have a mental health policy that includes pediatric patients, and yet only about 2/3 have behavioral health transfer plans. And this is really becoming a critical issue given the strain, the length of stay and boarding that many children are facing, and the decreased number of pediatric inpatient units that we've seen over the last 10 years. So within the EMS for Children Innovation Improvement Center, as Angela mentioned, we really focus on quality improvement, knowledge translation, and growing partnerships. And we have some critical partnerships with AAP, American Academy of Pediatrics, Emergency Nurses Association, and the American College of Emergency Physicians, but also with the American College of Surgeons, Committee on Trauma, and the National Association of State EMS Officials. Our work spans all types of facilities, from tribal facilities and rural facilities to children's hospitals. And our work is really to help increase access to high quality health services through these modalities of QI science, knowledge dissemination, and partnerships. For our National Quality Improvement Collaboratives, we leverage the Institute for Healthcare Improvement's Breakthrough Series model. And this is really a beautiful framework for how we begin to leverage improvement activities and quality improvement science across diverse groups and diverse sites. This particular topic, I think, requires no further introduction, as Dr. Schreiber provided a great background on the history and need for mental health. And that really formed the basis for this work. And over the last many months, our team has been working tirelessly to make sure that we have all the resources and tools available to you all to be most successful. We are currently at our first learning session, and over the next 9 months, as we continue on this journey together, what we hope is that each of you within your teams will identify an area of interest and or an area of opportunity for improvement, that you will go through a series of improvement cycles, often called plan, do, study, act cycles, and will be able to demonstrate improvements in care or clinical processes because of that. And the Institute for Healthcare Improvement's Breakthrough Series model is founded on their model for improvement. And it really centers around these 3 core questions. What are you specifically trying to accomplish? How will you and your team know if that change that you have made has indeed resulted in improvement? And what change will we make that we think will result in improvements? And we'll talk through this over the course of this collaborative. As we said, about a third of you may not have had any kind of QI training or experience before. A large percentage of you have not been involved in QI collaboratives before, and this is a new journey that we are all excited to take together. And we will guide you through the steps of a quality improvement project throughout the course of this. One of the great benefits of the QI collaboratives is that you get to learn and hear from each other. And I think that is indeed the greatest benefit, because you're all coming from diverse institutions that face significant challenges with respect to mental health care. And I know that because we're all facing challenges when it comes to mental health care in children. And yet you're here with a passion to make a difference. So we're so grateful to have you on board. But one of the benefits of our collaboratives, in addition to that, is that we have provided evidence-informed content to help drive some of the suggested change strategies and improvement bundles. We have centralized project management support to help kind of guide you through this process. We have centralized infrastructure with respect to data and analytics and IT. And ultimately, many of these collaboratives result in new knowledge that helps to guide the field in terms of implementation science and best practices. We do have other quality improvement collaboratives within the EMSC Innovation Improvement Center. I put these up here just so that there is some awareness. Right now, we're in the ED Stop Suicide Collaborative. For the EMSC state partnership managers that are on the call, we are planning a Pediatric Readiness Recognition Collaborative to kick off in September of 2023. And think about if you have an interest in that and building a team. And on the heels of the ED Stop Suicide Collaborative, we'll have what's called the Pediatric Readiness Quality Collaborative. And this is really an opportunity to take your QI project to the next phase, where you can now not just work on improving your clinical care processes or the policies, procedures, and structural measures that are in place in your ED, but actually looking at how those impact direct patient care. Within the PEDS Readiness Quality Collaborative, there will be a suicide-specific arm, and we welcome you all to consider joining that should you feel ready to do so. And then ultimately in 2024, 2025, we will be relaunching a collaborative focused on enhancing the role of pediatric emergency care coordinators. That's the PEC Workforce Development Collaborative that'll be kicking off in 2024. The ED Stop Suicide Collaborative is structured as you can see here on your screen. So we have some wonderful QI experts and subject matter experts across our team, but we've really identified some 4 to 5 core areas of focus for your improvement efforts. One, perhaps focused more on suicide screening or the triage pieces of this work. Second, focused on the mental health assessment. The third, looking at ED-based interventions and how to optimize those. The integration of family considerations throughout all of these processes or steps. And then lastly, disposition and safety planning. As we move to a more advanced stage in this collaborative, we are excited to be able to bring on some additional support from pediatric mental health care access grantees that will help us to identify and leverage regional resources that might be able to help provide additional services within your region or area. So for those of you that are in smaller hospitals or lower resourced environments, you may just be beginning this journey of how do we improve care for pediatric patients with mental health emergencies. And it may be that the first step you take is that around suicide screening and just trying to figure out ways to optimize that and use validated decision tools. Those of you who are more advanced may choose instead to focus on areas around discharge and safety planning or patient and family considerations. We are not dictating where you start, what you choose to work on. These are all available to you. So the reason that will be asking you to complete your own baseline assessment is that so you can identify which of these intervention bundles or areas of focus will be most important and valuable to you. For our SMART aim, our goal is that by the end of this year, 100% of you all will have identified and implemented at least one strategy to improve clinical care processes. So we're not asking you to hang the moon. We just want to see how we can support you to begin the steps towards improvement. These first 2 months are focused on orienting you to the overall structure of the collaborative. Next month, we'll be diving a little bit more into the quality improvement process and also into the specifics of these intervention bundles and strategies. So you'll hear a lot more about that in March. As we moving into April is when we really look forward to hearing more from you and each of the teams. So this is when, as a team, by April, we expect you all to have identified an area of focus, developed an aim statement that you are trying to achieve, and choose a strategy to make improvements. The months following that will be a series of improvement efforts. A lot of that work will be happening behind the scenes in your ED with your team. And then as we move into the fall, that's where we really have an opportunity to begin leveraging regional resources and establishing stronger partnerships with others who are participating. The Pediatric Mental Health Care Access Grantee Program is also a program that's funded through the Health Resources and Services Administration. And they have 50 awardees across the United States, 2 of which are in tribal areas. And they provide provider-to-provider mental health consultation for pediatric mental health emergencies. Their primary focus has historically been on primary care physicians, but we have begun working with a number of pediatric mental health care access grantees who are really interested in expanding their work into the emergency department setting to see how they might be able to help provide additional resources to emergency-based providers. So while we may not have a PMHCA program specifically in your region, I think there's a great opportunity to learn from each other about what are the barriers or challenges to potentially seeking their support. In addition, we have over 30 EMS for Children State Partnership Program Managers that are part of this collaborative. These individuals are an essential resource for you. If you don't know about your state EMS for Children State Partnership Program, you should. These are individuals that are 100% dedicated to improving pediatric emergency care in your state or territory. There are 58 EMSC state partnership programs because they also support our U.S. territories, so not just U.S. states. We have, as Angela mentioned, on the EMSC Innovation Improvement Center website, a list of the grants and the contacts for each of the EMSC State Partnership Program Managers. They are here to help support you, help identify resources that might be beneficial to you, and help advocate for your needs throughout the course of this collaborative. So we're really grateful and excited to have them as part of this. And then lastly, there may be opportunities as we move forward to think about how we can collaborate with school districts, primary care physicians, and the like. That'll be more for the advanced teams, but certainly available to those of you who are interested. So as we move into April, I mentioned that we will be hosting breakout sessions. This will be the time for you all to share with each other, learn from each other. And we know that can be extremely intimidating if we were all here in a big group. So what we have designed is a way of breaking up this collaborative into smaller groups of about 7 or so teams per breakout session. And in those breakout sessions, each team will have about 5 minutes to present on their project and their work, what successes and challenges they have. This is not intended to be a heavy lift. It's really, a 5-minute presentation just where you can share with others some of the work that you're doing so others can learn from you. The question we would like to ask for you all is, what do you think would be most beneficial to you as we assign breakout groups? should we assign those based on the specific area you're working on? In other words, you just want to hear about screening. If you're working on screening, what are the strategies that are being used? Or would you rather learn from other hospitals that are similar to yours, that maybe have similar types of resources, such as rural hospital groupings or children's hospital groupings? Alternatively, we could develop regional breakouts where you're surrounded by others within your state lines or within your region. And then lastly, we could look at random assignment. The challenge here is that you may not get to know everybody quite as well with the random assignments, but we're happy to do that as well. So we're going to launch a poll here, and we'd love to just hear your thoughts as we begin to think about this. Because this is a collaborative, it is iterative in its approach. And that means that if something's not working, we can pivot. We're here really to help support you. So did the poll launch? Yes, wonderful. So we're going to give you all just a few minutes to please let us know what you think would be most beneficial for you as you listen to others within your small breakout, who you want to hear from and what you want to learn. If you haven't responded, we'd still love to hear from you. Most everybody has. Okay, I think we've leveled off. So thank you all for those who responded. We're seeing a fairly even split between bundle specific and some similar hospitals. So maybe we'll try one and see how that goes, and then figure out some other approaches as well. But this is really helpful to hear. So thank you. Okay. So just as we mentioned in the registration welcome and the call for participants, one of the items that we asked was that you try to identify at least 2 individuals to be part of your team. And the reason that this is so important is that quality improvement efforts require different perspectives and different approaches. We estimate that this will take somewhere between 2 and 8 hours per month to complete this work or be involved in this work, but we really defer to your team on your bandwidth and availability and what you can accomplish. Ultimately, our goal is that you identify a need, seek buy-in from your hospital or ED leadership, and then begin to implement those changes to assess impact. One of the tools that we sometimes refer to in the QI arena is a stakeholder grid or a power interest grid. And this is just a way of thinking about the individuals within your organization that you think might need to know about or be involved in the work that you're about to undertake. And I would encourage all of you to really think about communicating and talking about this project with ED leadership and potentially even C-suite or hospital administrators. I think the more they know about the work that you're doing, the more they can support it and make sure that it's successful. You've heard a lot of the background, and again, we're going to be posting this recording up onto the EIC website. So if you're just trying to learn a little bit about the need and the background and the science behind why we're doing this, you can always go back and listen to those, the recording again, and use that as you begin to develop your own message to ED leadership and or hospital leadership. Many of the teams have very diverse groups of individuals on their team, which is really wonderful. And these are just some suggestions of people that you might include on your team if you haven't already. And in some sites, you might even have an ED leader, like a nursing director or ED medical director, or a C-suite administrator who's actually part of your team because they have a vested interest in this work. The idea is that if there's someone who's really interested, you want to either keep them informed or keep them engaged in this work. And for those particularly that have the ability to influence or provide support to this work, you want to make sure they know about it and can provide additional input. For each site, we hope that you will develop an improvement project that follows on the framework of the Institutes for Healthcare Improvements Model for Improvement. And as you think about doing this, there's some key questions that you might want to ask. How are you going to communicate your work with other stakeholders at your site? So do you have a means set up where you can meet with ED leadership or other stakeholders? Do you have a communication strategy that you've begun to think about or develop? So just be thinking about how you will communicate with these stakeholders in between our learning sessions as you're doing this work. You might also start thinking about what changes you might want to implement. It might be that within your emergency department, there's already a huge interest in looking at mental health assessments and how to do these more effectively. That might be the one where you have the greatest cultural buy-in. And so it might be the area of focus, even though there may be some other opportunities for improvement. And then the last thing is, if there are already ideas about areas of change or strategies that have significant support or that have worked previously with other quality improvement projects, we'd encourage you to think about reutilizing those to fit this particular project. So just to review the IHI model, it's what change do you seek? Is that change actually resulting in improvement? We'll talk a little bit about measurement next time and how you actually measure those improvements. And then finally, what change strategies do you think that you'll implement as a result of this? And those change strategies might be educating staff. It might be putting up knowledge reinforcement tools during triage. It might be creating the right infrastructure or space for safe rooms for these children. Lots of different types of strategies that you might undertake, and those are just some suggestions. So just a couple more slides, and then I'm going to turn it back to Laura to take us through some of the logistics. But if you are the team lead, we will be sending out after this session an environmental scan. This is really a baseline assessment of the resources that you have for managing pediatric mental health emergencies specifically. And the questions that we ask are directly a crosswalk to the intervention bundle guide. So as you begin to look at these questions, you'll see, oh, this might be an area where we could work on because we don't have this in place now. So it's really intended to be informational for you. We would like for you to complete it with your team so that you all can have a discussion about where you want to focus your work. Think about how you're going to convene meetings with your team between these sessions. How often will you meet? What type of bandwidth do you have to support this work? And then during our learning sessions, we really do want to make sure that as a team, you all are sharing your activities, successes, challenges, and we will be providing 3 to 5 set slide templates that will help you in sort of planning that breakout session. So again, this is not intended to be a super heavy lift, but it's really important that you all get to hear from each other. And then for those of you who are not serving as the team leads, we still do want to hear a little bit about your background. It's helpful for us to know what degree of quality improvement experience you have so that we can hit the needle on the mark next month when we talk about QI. It's also helpful for us to know a little bit about your background and experience in the emergency department setting, and really just a lot about who you all are. We know that we have some folks that are from security, some folks that are physicians, some folks that are EMS providers that are working in the emergency department setting. So that's helpful for us just to know who our audience is. We'd like for everybody to try to participate in these monthly learning sessions. It's only once a month. They're always on the first Thursday of the month, always at this time. And we hope that you're able to clear your schedule accordingly. And then, of course, working with the rest of your team on the QI project. So at this juncture, I'm going to turn it back to Laura, who's going to talk a little bit about resources and logistics.
Thanks, Dr. Remick. I also wanted to recognize that there are many colleagues on our team who are helping behind the scenes, and several folks who stepped up to speak when the scheduled speakers had problems with the power outages or Wi-Fi shortages. So thank you so much. I particularly wanted to call out my colleagues, Christina Madero and Eleni Belardos, for all the help that they give every day. They do a lot of the logistics of behind the scenes. Next slide, please. All right, Kate, Dr. Remick has also mentioned many of these resources that are available to you. There will be a welcome packet that is coming to you shortly. She's mentioned the environmental scan. To add to what she has said, you will see the questions first so that team leads can check with their team participants to make sure that they know all the answers before they go in to enter the REDCap survey. Again, the questions will come to you shortly and the survey link within the next few days. I'm not moving the slides, but they seem to be moving. Okay, let's try this again. So Kate's already mentioned most of the other items. The fireside chats will give you a little bit more information on it. You will have some opportunities to get some support from QI and content expert coaches. We've already discussed the breakout group discussions and the brief reports that we want to hear from you on how well things are going or are not going and where you might need help or support. And then we will offer tools to support you in identifying your focus area, where you want to focus your improvement, whether it's a larger, more complex QI project or a clinical change process that is shorter, such as training your staff on how to use a specific screening tool. Next slide. Thank you. So the welcome packet and the QR reference guide, initially one packet, we are now dividing into two to get information to you more quickly. The welcome packet will come to you within the next few days, and it includes what you see, which is basic information to help you move through this collaborative, similar to what we're presenting to you today, only more focused on the step-by-step. The intervention bundle guides, it's an interesting term. So the bundle guides, as you've seen, focus on suicide screening, mental health assessment, ED interventions, as well as discharge and safety planning. So these bundle guides are short, 5 to 10 pages at most, and designed to help you move through your QI project or improvement process focused on that topic area. Your teams will be given quality measures or outcomes to strive for, but you will be asked to identify your own SMART aim and design your own project to make sure that it is most relevant to your ED site. And as Kate mentioned, we want everyone to participate in the decision-making process, and that might include either group emails or having actual team meetings, whether they are virtual or in person, in between collaborative sessions. We have some additional resources that you may or may not be aware of. The EIIC produces pediatric education and advocacy kits called PEAK resources. So if you use the QR scan code, you'll get to the list. And there are several that are relevant to this particular collaborative. So there is a peak suicide. And one of the things that's cool about this resource, which you can find online, is that it not only includes resources and backgrounds and tools, but there are several podcasts that you would be interested in hearing about, a little different from our fireside chats, which are meant to be more casual, didactic at first, but allowing you the opportunity to ask questions and feel comfortable moving forward with your QI project. But the peak suicide is one, and then there is another peak on agitation that you might find useful depending upon which topic you're working on. The American Academy of Pediatrics does have prevention materials, including a suicide blueprint for youth prevention. document. It's actually a website based on a multidisciplinary large meeting that took place a couple of years ago. I believe some of you who want to focus on prevention or community outreach will find it quite helpful. You've already sort of seen this before. The approach for the 8 sessions specific to this QI collaborative are divided into phases. So right now we're in the orientation phase. The first 2 sessions are more presentational to make sure that you have all the background information that you need to feel comfortable moving forward. As we move into the mobilization area, you will discuss and identify your area of QI project focus, actually declare it, review the relevant intervention bundle and topic materials, and develop your own team's SMART aim and strategy to move forward. Later on in the collaborative, there will be opportunities where you will be able to see how change is actually taking place, or to change your approach if you feel like that things need to be adapted. And again, as Kate mentioned, the pediatric mental health care access grantees or partners will be joining us to support you in learning more about telemedicine, telepsychiatry opportunities, and leveraging community resources. Lastly, we'll move into sustainability, where we hope that throughout the collaborative, you will have been able to establish partnerships with other teams like yours or different from yours, as well as to celebrate your successes. The SMART aim for the entire collaborative has already been mentioned by Kate, and we hope you all will achieve it. It's right there on the left. So this is a graphic of the learning sessions and the fireside chats to show you what things look like. The green represent the collaborative learning sessions, the first Monday of each month. Just a reminder, in case you didn't pick it up in our emails, this particular one used a single Zoom link. In the future, we will ask you to register individually, and we will explain that process. And then we will know how many people are planning to come to each collaborative, and that helps us with our groupings for breakouts because we'll have to plan in advance. The fireside chats or presentations by experts with opportunities for you to ask questions are in red. They are the other Thursdays in the month throughout February and March, all occurring at noon Central Time, except for one that will occur later in the day to accommodate that particular expert. Kate, was there anything else that you wanted to mention about the fireside chats?
I don't think so. This is a great opportunity to really learn from subject matter experts, and you'll hear them talk about some of the strategies that they've undertaken and really get a better understanding of some of the work that you may be undertaking in the future. So we encourage you to join those, especially those that are focused on your area of interest. So it will be extremely valuable to you.
Thank you. So you can see the dates of the sessions outlined here. You should have a placeholder appointment in your Outlook calendar. If you don't, when you're asked to register for the upcoming collaboratives, you have the opportunity, you'll receive a customized link, and you will have the opportunity to adapt that into an Outlook calendar appointment for you. So we will not remove the placeholder appointments, but you may see some changes to those appointments, encouraging you to register for each session. You'll notice that in July and August, because so many people have vacations and other time off in July and August, as well as the fact that we want to give your teams time to work on your QI projects, we are not having sessions. Instead, we'll have a 1-hour open office hour planned for noon to 1 Central Time. At this point in time, you can pop in whenever you have a question. You're also welcome if your team wants specific consultation or guidance, or just has some questions, you can email or you can ask for a virtual meeting and we will help you along the way. You've heard about the breakout sessions, and thank you so much for completing your poll. And the presentations that you will be asked to give after the first few collaborative sessions will do exactly what's on the screen. And that's been described to you before. We will give you a brief slide template, as Dr. Remick mentioned, to help you prepare your thoughts. And this may change over time as your QI project moves forward and you learn from that and you want to share your challenges, barriers, and successes with others in your breakout session. Fireside chats. Here is a list of when they are scheduled to happen, and the experts. I'm sure some of you have heard of these folks before. And then the bundle or topic that they are working on. There may be one or two more that get added. I do know that we're definitely going to have someone from the Pediatric Mental Health Care Access Grantee community talk about telemedicine and leveraging regional resources, which is the focus of their efforts. And they have a lot to add to what we are providing to you. Continuing education, we are so thrilled to be able to offer this to you for free. MOC credit for physicians begins with today's session. Overall, you can earn up to 25 credits. We need to make sure that you're attending sessions, completing the session evaluation, and then there's the usual form that you submit to us and you will be granted credit for the time that you put into this collaborative via sessions. Nursing credit application is in process. We believe that it will be available no later than the next session coming up. And there's an update. The social worker application was approved today and credits are available as of right now. Action items. I think you've heard a lot about all of these. Please complete the participant demographic form. It's important. The environmental scan is even more important because it gives you a baseline as to where you are related to specific pediatric suicide clinical care processes. We don't expect that all of you will be able to say that you have these clinical care processes in place. We know that some of you might not have many or any at all, but it will help us understand our audience and it will help you make a decision on what you need to do to improve. And you will be able to see change over time as well. Some final resources for you, web pages. The ED Stop Suicide QI Collaborative web pages will be updated within the next few days to provide you with additional items, including the session recording and slide, as well as the welcome kit and additional resources, some of which you've seen today. We're getting ready for that live post-session evaluation, so just be ready to move into action. At the end of the collaborative, we will do a post-collaborative evaluation because we want to see how things have changed over time, and we're interested in your feedback as to how we could improve future collaboratives, especially if we consider doing a second collaborative on this topic, adapted for its own improvement. The word cloud you see on the right is based on those of you who did answer the demographic form and you explained why you were joining this collaborative. So I'm grateful to my colleague Tracy Edwards for providing that information, and also to Julie Shelton for doing some other summaries that you've already seen presented. Okay, I think that the questions are being answered along the way. I will say that we are looking into additional credits that may be provided, including some of the ones mentioned in the chat. I'm just looking to see if others have questions. Would any of the panelists like to make any comments or share things that they might want to emphasize as we wait to see if folks have questions? Dr. Remick, there's a good question for you in the chat.
How will the state partnership managers participate in the quality improvement if they're not part of a hospital team? So this is really about trying to provide support and understanding some of the strategies that are being undertaken. So as EMSC state partnership managers, we hope that during these breakout sessions, you can learn and begin to compile some best practices that might be used to share with other sites with whom you partner, with whom you work. So this is really an opportunity to learn a little bit about QI, and then also to learn about some best practices that are being undertaken or the challenges that are being faced. And then there's a question about CEUs. So Laura, I'll turn that to you.
Okay, just a second. Angela Nguyen is sharing information on social work CEUs. We will follow up with the details related to CEUs for MOC, if you're not familiar with that, as well as for nursing. In terms of how do you add members to the team, my guess is that 80% of you know this, and so it's a great question. You simply email one of the staff, and that would be myself. My email is right there in the chat, laura.aird@austin.texas.edu, and then my colleagues Eleni and Christina, or anyone really here, can help point you to us so we can add team members. Any final thoughts from panelists? Thank you, Kate.
Mm-hmm. All right, well, I think we should move on to the survey and give everyone 15 minutes back in their day. Got a quick survey we're going to launch, and we really appreciate you all for joining. We're excited to work with you and get to know you over the coming months. Thank you so much, Dr. Schreiber and Angela, for your wonderful presentations. Really grateful for your partnership, and you will be meeting future experts as we go. So thanks everyone for joining today.
Okay, we see that some of you are noticing that your survey appeared but then disappeared. I can still see it on my screen. Do others have ideas about how we might help these folks? Oh, it's back now. So I'm hoping it's back for all of you. 8 questions. And you're starting to answer. Thank you so much.
We promise we won't be emailing these evaluations out, so we thank you for doing it this way. We try to get you in the moment. Thanks so much.